You can start, Ayman.
Okay. Good evening, everyone, and welcome to the Gender, Health and Wellbeing webinar. I request Jashodhara, who is a convener of the Feminist Policy Collective, to start the webinar and give us some background before we actually begin. Thank you, Jashodhara.
Thank you, Eman, and thank you, everyone. On behalf of the Feminist Policy Collective, a very warm welcome to all our attendees and, of course, our esteemed discussants and all our panelists. Just for those of you who don't know, the Feminist Policy Collective is an independent and voluntary network of academic researchers, policy experts, and women's rights campaigners. And all of us are committed to strengthening gender transformative policies, plans, and financing in India. We came together as a collective in February 2019, and we're really proud that we have completed 5 years. For those of you who would like to know a little more about the Feminist Policy Collective, please do check out our website, which is, in small letters, feministpolicyindia.org. And you will find details about our organization, the work we do, the kind of knowledge products we have put out, and of course, our key event of the year, which is the pre-budget consultations towards gender budgeting. So to come back to this webinar, I'm very happy to welcome you to the first of our series of webinars, which is towards introducing the India Gender Report 2024. So the India Gender Report is actually the first such report that examines the gendered aspects of India's people through the prism of transformative finance. So the India Gender Report, which actually has been led and anchored by Professor Ritu Dewan, who I think unfortunately could not join us today. We're really missing Ritu. This is a report that is in 5 sections, and each section has several chapters that provide the detailed information and analysis that we have been able to pull together. So the 5 chapters of the India Gender Report 2024 are transformative financing and development, work, labor and livelihoods, gender, health and well-being, gender-based and sexual-based violence, and finally, education and skilling. So, of course, this is a report that has been largely a labor of love from the members of the Feminist Policy Collective, but we have been extremely privileged to have several other scholars and researchers join this endeavor and work together with us, given the challenges that there is hardly any gender disaggregated data on most issues. And definitely, whatever there is within the gender binary, which creates a significant hurdle. So as I said, the editor of this report is Dr. Ritu Dewan. She is unfortunately not with us today, but every section has a section anchor. And the anchor for today's section, which is on gender, health, and well-being, is Nilangi Sardesh Pandey, who will be addressing us in a couple of minutes. So this webinar series is aiming to introduce the feminist analysis that we have come up with on every section one by one. Today's webinar is on the section 3, which is gender, health, and well-being. Some of you have asked us, where is the report? So the report is going to come out at the end of these webinars. So picture abhi baki hai, this is the trailer. So over to Nilangi, who is the anchor of this section 3. Nilangi, over to you.
Thank you so much, Jashodhara, for providing this background about the India Gender Report. And like Jashodhara said, that we have been working for several months on this now, and it's a great pleasure for me to actually now see that webinar is happening. And we are very thankful to all our authors who are present here today to present their work. So what I'm going to do in next 5-7 minutes is just provide a broad overview because the authors are going to speak about the key findings. So basically, when we talk about gender health and well-being in this section, what we are doing is we are looking at health policy and financing from a gender perspective. And so basically, we have also included the word well-being because we wanted to go somewhere just beyond the health status. So when we say well-being, we obviously thought of the quality of life aspect. So like, for example, in the chapter on the infectious diseases, there is one whole section about the role of caregiving for women for HIV. So this talks, like this brings out a lot of gender dimensions of the caregiving. So even if we talk about one disease here, the findings and the issues are applicable for all such diseases where there is stigma. This overall, this health section has 6 chapters. So the first chapter begins with the laying foundation by the giving the overview of the health system in India. And here, actually, we are in this chapter only, we are taking a historical overview. For all other chapters, we have tried to restrict ourselves to the policies and programs in the last 15 years, sometimes just like last 2 decades, but mostly it's been last 10 to 15 years. But this is one chapter where we are giving a historical overview since post-independence till now, how the health system has been changing and what are the gender, like what are the missing things from the gender perspective, in fact, because most of us, we know that how the current health system is actually lacking that gender perspective. And when we talk about the health system, it's not just the public health system that we are focusing, but also the private health sector is what we are talking about. The chapter talks about the health financing, the health system structures, and the human resource management. So once we have talked about this health system, the report then actually picks up 2 key determinants of health. And here we have taken nutrition and women's work as 2 determinants, which will talk more about the gender aspects of the reasons, like gender reasons behind women's illnesses. And so that is the reason, one of the challenges for this report has been that what should we pick up, because in terms of there are several determinants of health, but we have decided to focus on these 2 also, because like women's work throughout the other sections of the report also, we have been talking about women's work, so it was quite logical for us to delve into the health aspects of women's work. And nutrition is obviously because we have a high prevalence of malnutrition, and also because it's one of the important determinants for women's health. So that is the second and third chapter in this section. Then we go on to talk about the key infectious diseases. And here we have picked up actually, and we have analyzed the gender dimensions of tuberculosis, HIV, and malaria. And Sandhya is with us here, and she will talk more about the findings from these infectious diseases. And subsequently, we talk about the non-communicable diseases. So it's basically among the non-communicable diseases, we are covering the cardiovascular diseases, respiratory diseases, diabetes, and cancers. And aspects of mental health are also included in this chapter on the key non-communicable diseases. And the last chapter of this section is about the reproductive health. Usually when we talk about women's health, people equate it with reproductive health. So we have very consciously kept reproductive health as the last thing, because we wanted to highlight other health concerns of women more than the reproductive health. And within reproductive health also, usually maternal health gets highly focused, and we have tried to see that we will look at other reproductive services as well, including services for infertility, and RTIs and other women's reproductive health concerns, including the reproductive health concerns of the postmenopausal, which is often one of the neglected areas. This is what this whole report consists. There is no claim that this is comprehensive, but because there are several other diseases that could have been included, but what we have tried to do is look at some of the key diseases, and then through that as a case study, trying to highlight the gender dimensions. Like I said, generally we have analyzed the policies, programs around these issues in the last 10-15 years, and bring out the feminist critique for those. Also, throughout the report, the health section, you will see that equity and rights, these are the two perspectives which are pretty dominant in our analysis. And for example, when we say the reproductive rights is one such part, most of the analysis, And so, for example, the recommendations for addressing malnutrition, we just don't talk about, like DIPA has not just talked about the services for providing nutritious food, but also talking about the policies to tackle the structural inequalities. So this is how overall the ethos in which this report has been brought out. So I'm sure that after this brief overview, you all are more interested in listening to the authors and of these chapters. So it is my pleasure to welcome our esteemed panelists today. And since we want to dedicate more time for listening to them, I will introduce them very briefly. Actually, in a sense, they don't need introduction because I'm sure some of you, like many of you, have read their work. But I'll just introduce each one of them in a few sentences, and then we can actually begin with the presentation. So our first panelist is Ravi Duggal. Ravi is a sociologist and works as an independent researcher and consultant. He was one of the founders of Sehat in 1991 and has worked with several international platforms. For over 4 decades, he has been involved in health services, research, advocacy, and training with a large number of publications. His areas of expertise are related to health economics, health systems, and health policy, budgets, decentralization, governance, and social accountability, and social sector policies and social security. So welcome, Ravi. I will finish introducing all the panelists, and then we will begin with the presentation. The second presenter is Deepa Sinha. She is the author of the nutrition chapter. Deepa is a development economist with about more than 20 years of experience in teaching, research, and policy advocacy. Her areas of expertise include social policy, especially related to public health, food and nutrition, gender, and child rights. And she has taught at the Ambedkar University, Delhi, and has been part of large international research collaboration. She has been also part of the various policy-related committees of the state and union government, and she is actively involved with the Right to Food Civil Society campaign in India. After Deepa, we will get an opportunity to listen to Padmini Swaminathan, who has authored the chapter on women and work. So Padmini Swaminathan is a renowned scholar who has been the former director, the Madras University Institute of Development Studies, and a professor at the School of Livelihoods and Research, Tata Institute of Social Sciences, Hyderabad. Her publications cover themes of industrial organization, labor and skill development, occupational health, from a gender perspective. After Padmini, we will listen to Sandhya Srinivasan. She'll be presenting from about the key infectious diseases as well as non-communicable diseases. Sandhya Srinivasan is a freelance journalist, researcher, and editor who was executive editor of the Indian Journal of Medical Ethics for almost 14 years, and she has worked on national and international projects. She writes on ethical issues in healthcare and research, including the emergence and dissemination of assisted reproductive technologies in India and concerns around international drug trials. Our last but not the least speaker is Rashmi Padhe. So she will basically present from the chapter on the reproductive health. Rashmi is a freelance research consultant currently attached to Sahaj Vadodara. She has been working in the development sector for the past 18 years. Her health sector experience includes work on health equity, health rights, health systems research, determinants of health such as nutrition, water and sanitation, and gender aspects of health. So it's a huge privilege for me to present all the panelists to you. So may I request now Ravi to start with his presentation. Generally, we are saying that around 7 to 8 minutes you can take for your presentation because we also have allocated some time for the Q&A with the participants. So is it okay if after 7 minutes I just indicate that 1 more minute, or maybe I will switch on my camera so that just to not to disturb you when you are speaking, for all the speakers I'm saying. So maybe around 7 to 8 minutes, I'll switch on my camera, and in case it is exceeding 8 minutes, I'll just let you know. Yeah. Okay. So welcome, Ravi. You can start your presentation.
Yeah, thanks, Nilangi, and thanks to the Feminist Collective for making me a part of this process. Yeah, it was a kind of a task to do this chapter because, as Nilangi said earlier, that gender disaggregated information is a challenge. So that still remains a challenge. Anyway, so broadly, I think what this chapter covers is we begin with a historical perspective on how the health systems in the country have evolved, starting with the Bore Committee report, where we had an excellent kind of plan, which was based on hard evidence gathered from the field, called the Bore Committee report recommendations, which was like almost like a national health system that should have been implemented. Unfortunately, the first health ministers conference in 1948 kind of said, yes, it's a great document, and but we don't have the resources to implement it. At that point of time, the recommendations for the Bore Committee, the financing required was about 1.8% of the gross national product, which would have been at that time about 15% of the total budget. So this was something which the government had different. The Mahalanobis plan with Nehru had different kind of focuses, focusing largely on developing huge infrastructure like irrigation projects, highways, and so on, building institutions of excellence. And so that was the focus. So, but what we see is that there are two countries which actually implemented the Bore Committee report, which is Sri Lanka and Burma, then Burma, now Myanmar. So where we do see kind of elements of the structure that the Bore Committee had talked about for the healthcare system. But in India, we had the 5-year planning process through which action on health and all other kind of development activities evolved. And in health, I mean, the approach of the 5-year plans was to look at certain priorities, and which was a segmented approach, and they kind of identified certain key issues and developed schemes and programs for that. So like the malaria program or the TB program, family planning program, and maternal and child health, and so on. So various kinds over the years, various kinds of segmented activities in silos were kind of planned and were implemented. So targeted schemes with targeted population also. So this segmentation of the healthcare system has been the foundation of the evolution of the system in the country. And instead of kind of what was then called basic health services approach, and today we call it comprehensive primary healthcare approach. So that foundation somewhere got lost in this whole process of development of the healthcare system. So like the Bore Committee said that there should be a primary health unit for every 10,000 population, each having about 30 to 50 beds, which was a big kind of ask at that point of time. Because today, even today, the primary health center that we talk about is for 30,000 population with 6 beds and 1 doctor and so on. I mean, the Bore Committee talked about 6 to 10 doctors. They talked about that there should be enough women doctors also, and so on. So they did at that point of time whatever was viewed as being gender just. So there were a lot of things like they had talked about creches and things like that. So that was the historical foundation where we missed the opportunity. And through the 5-year plan process, we started developing schemes and programs, and also an infrastructure which was very kind of weak. I mean, we began with 1 PHC per 1 lakh population and so on. But it was only after the 1982, the first health policy since independence, that we kind of narrowed down to saying that we need a structure. And this was the Alma Ata Declaration influence which shaped that policy, and the ICMR-ICSR Joint Committee on Health for All, which shaped this policy. And a proper structure was being talked about for the first time, with the PHC for 30,000 population, 20,000 population in tribal and hilly areas, and so on, with community health centers and sub-centers, and then the district hospital and other sub-district hospitals. So this is the broad structure of the healthcare system that we have today. Apart from this, we also saw the initially a gradual growth of the private sector, but since 1990s, a very rapid kind of growth. And that coincides with kind of reduced investment by the public sector in health and healthcare. So somewhere these go together. And we see that the segmented approach continues even today, where, for example, there is a substantial focus on women's health with MCH and family planning, but these are women are seen as targets and certain targets to be achieved. So this is what we have kind of evolved over the years since independence. And so the first consolidation took place post the first national health policy in 82, when the structure was kind of consolidated that I spoke about through the minimum needs program. And much later, the National Health Mission became the second kind of intensive approach to try and kind of consolidate the healthcare system, the public health system that we have today. But post 1990s, I mean, the entire political economy of health kind of got a twist where the larger focus shifted to the private health sector. The private sector suddenly began to grow rapidly, and this was on the foundation of a few pillars like the privatization of medical education. So there was a huge kind of production of doctors in private medical schools. And obviously, if you go to a private medical school, you pay crores of rupees, and then you want a return of investment as quickly as possible. So as a healthcare system, so this was the first pillar. The second pillar was insurance that came in, and then the corporatization of the hospital sector. So corporate hospitals, even today, probably cannot function without health insurance, because even for the upper middle classes, I mean, they can't afford to directly use corporate hospitals where you get higher levels of tertiary care. So you have to have an insurance backup. And so that is how the private health sector evolved since the 90s, since our structural adjustment of the economy that happened, and public-private partnerships, the state supporting the private sector through programs like PMJAY, etc., became quite rampant. And though, I mean, schemes for women continued to be there within the healthcare system, but again, targeted schemes like JSY, JSSK, and so on. And of course, RCH and MCH, etc., continued, and family planning program is still there in place.
Ravi, just one more minute for you.
Yeah, but we see that within the public health system, whatever we have today, there's a huge amount of discrimination, both in terms of gender and caste, with the way the resources that are allocated, grossly inadequate resources. We are spending only 1.2% of our GDP for the general healthcare system. But again, in the financing of healthcare is highly segmented, because you have groups of population like the central government employees or the organized sector employees who have the cover of social health insurance. So for example, CGHS spends 15 to 16,000 rupees per capita for the population that they cover, as compared to only 2,000 rupees per capita for the general healthcare system in the country. So there's a huge kind of discrimination that we see. And then again, and because of this lack of investment and poor infrastructure and provisioning of the public health system, people are forced to use the private sector when they need to access healthcare. And that kind of increases the huge burden on households in terms of out-of-pocket spending. And so this is kind of an overview. So this chapter kind of gives you this overview of how the health system has evolved, how the financing has progressed. And today we are relying increasingly on insurance as a mechanism of financing. We are moving in the direction of a US-based kind of healthcare system. But I think the only way out, I mean, I'll just end, is to kind of build a strong foundation of comprehensive primary healthcare approach, wherein the public health infrastructure is strengthened. There are some kind of ideas which are progressive in terms of the health and wellness center concept, which came in, which kind of improved the focus on curative care in at the sub center and primary health center level. But then we have this huge human resource kind of deficit. It's not that we don't produce doctors. We are producing more than 1 lakh allopathic doctors every year. But despite that, the public health system doesn't get the resources. There are huge vacancies, 70 to 80% for specialists.
Yeah. So, Ravi, maybe some of these issues we can take up during the Q&A session.
So this is what we have. And if you need to move towards UHC kind of system with equity, then we have to talk of right to healthcare and see that there's legal mandate for all this. Thank you.
Thank you so much, Ravi. I can understand the challenge to summarize, this whole chapter in 7 to 8 minutes, and we are really sorry for giving a limited time, but we wanted more voices and also allocate some time for our participants to share their questions and some discussion around that. So may I now request Deepa to go ahead with her presentation. So like I said, just a minute before your time is up, I will start my video.
So, thank you. Thank you, Nilangi. I'll quickly be presenting the chapter we have on nutrition and gender. In fact, initially when we were planning the report, there was no separate chapter on nutrition. It was supposed to be a box, but eventually we went with a small chapter. Even before we get into the gender aspects of it, I think as is well known, the situation of undernutrition in India for everybody of all genders is quite poor, particularly even when we look at the improvements over the last few decades and compared to the economic progress that India is making. So we just start with a broad discussion on the trends in malnutrition, showing how stunting and wasting are both still quite prevalent amongst children under 5, although we do see some amount of improvement over time, that this is something that is still an issue of serious concern. Along with these anthropometric indicators, you find that even in the case of anemia, in fact, we see some increase in anemia in both in children and adults among women. But in both these instances, when we look at it broken up, I'm not presenting all the data here, but when we look at it broken up by gender, then you find that, in fact, in the anthropometric outcomes, there is not a very big gender difference that you see. And this is something that people who work on nutrition data are familiar with. So, for instance, the prevalence of stunting or wasting between boys and girls is not very different. And sometimes girls are slightly better off. And in anemia, of course, there is a difference where anemia is much more amongst women. A caveat here also that most of the data is available in this gender binary, and therefore, although we recognize the disadvantages that people along the spectrum could have, and people of transgender, but we are not able to discuss that very much over here. So although in outcomes you don't see much difference, we also know that, like we see in the case of anemia, and there are also periods in a woman's life cycle, particularly during pregnancy and lactation, where there is an additional need for nutrition. And when we look at food consumption, there is very little data on food consumption in the country, particularly at individual level. So whatever little we have from the CNNS and NFHS5, we look at that. And this, again, not going into the details of the data, but broadly what you find is that you don't see much significant differences between girls and boys in terms of children, in terms of the access to food that they get. But as the age increases, you do see a gap. For example, if you look at from NFHS amongst the 15 to 49-year-olds, the people in reproductive age, you find that about 45% of women consume eggs at least once a week, whereas that number is much larger, 58% almost for men. So this difference in food consumption is something in the data that you see later. But we do have a lot of other qualitative evidence which also tells about the access to better quality of food within the household and so on, where men, even amongst children, male children, get a preference. However, so the chapter looks at all of this data and also focuses, even more importantly, at the status of women as one of the most important underlying determinants of undernutrition in the country for boys and girls. The overall child malnutrition and the poor status of nutrition is very closely linked to the status of women. And here it is linked to the status of women in multiple ways. One that we discuss quite a bit and we are aware of is the role of women as primary caregivers. And we know that this work that women do within the households of taking care of children is not recognized as work. And as a result, also there is a lack of supportive systems and mechanisms which affects then child feeding and nutrition outcomes as well. So here primarily it is maternity entitlements and childcare services in this context that we discuss. Of course, women as childbearers, there is a direct implication. If women are anemic, they don't have good access to nutrition. Women get pregnant, that the intergenerational cycle of malnutrition is perpetuated. And here the poor access to services that women have. And of course, through all of this, it is also the intersectionalities that we talk about. All women are not the same. There are heterogeneities, women belonging to Dalit, Adivasi communities, poor women, women in rural areas, have greater difficulties in accessing these services. In the context of food and in the context of nutrition, very briefly, we also mention looking at women as farmers, because on the one hand, you have women being primary producers of food, not just through agriculture, but collection of food, kitchen gardens, and then, of course, cooking food at home. But this entire role of women not being recognized. And although they are doing this primarily in terms of access to services, it's not only access to direct nutrition services, but access to agricultural services, credit, input, ownership of land, and so on, which affects the dietary diversity that is available, is something that gets affected, where women, despite being farmers in terms of the amount of farming work that they do, not actually being recognized as farmers. Then when we also look at women as beneficiaries of various public programs, like I've already mentioned, a number of services that need to be in place are missing precisely because of this sort of gender discrimination that exists and the situation where women's unpaid work is not recognized as work. Therefore, the gaps that you see in coverage and in budgets for programs which are directed at women and children, where over the last 10 years in programs like ICDS and midday meal, we see that the budgets in real terms have actually been declining. Budgetary allocations for programs like maternity entitlements, which have been stagnant and declining in real terms. We look at all of this to show how this has been a neglected area. And so one is there is a gap in what is in the programs that are available. But secondly, also that what is even there in place is not of good quality enough, and probably the access is becoming worse off because the budgetary allocations are really poor. Related to all of this, I mean, so it is important to just bring in all these dynamics of gender when we think about nutrition, and that in the context of something like the India Gender Report, it's not just about nutritional outcomes and how they are gender differentiated, but also how this is very closely linked to status of women. So just to finally, one other point, which is quite important here, is to look at the service providers of women in nutrition and health programs as well, which is mainly the Ashas and the Anganwadi workers who provide health and nutrition services, who themselves are overworked and underpaid. Once again, linking back to our first point, that women's unpaid work and care work is unrecognized, that this gender segregation of occupations, gender division of labor is something that we see within the household, but also within people who provide it through the state, where their incomes, their wages are low, and the governments get away with this because it is again women's services and women are doing this, and this overall affects the quality of services that are available for women as well. Nilangi, I'm done.
Yeah,
So
no,
it's broadly,
really feeling glad for stopping all of you. But I really like the way you have emphasized on women's role as farmers. I think this is something which we often miss out. Generally, the discussion is around women as caring for children and cooking and all. But I really appreciated this point. I would now like to request Padmini to start her presentation about women's work and its impact on health.
Thank you, Nilangi, and I want to thank Feminist Collective for having me here and in, allowing me to write this particular chapter. So, what is it that I have done in this particular chapter? I have revisited unresolved issues while also examining new challenges. So that is, I would say, one of the things that I've tried to do in this particular chapter. What is the structure of the chapter? I have 3 sections. The first one conceptualizes linkages between women's work and health outcomes. The second one recapitulates. So what I've done is I've taken earlier work that has been done on occupational health and then tried to see what is the current situation in some of the sectors that was covered earlier. So it recapitulates occupational hazards faced by women and as documented by researchers and official bodies. It also provides recent information on some of the sectors to give an idea of whether anything has changed for the better. So that is the whole idea of revisiting some of the sectors that were covered earlier. And in section 3, I emphasize that while there is official acknowledgement that occupational safety and health about occupational health, it has not received the attention it should. Very little attempt has been made to operationalize officially approved recommendations. So it is not that we don't have recommendations, but they have not been officially acknowledged. They have been officially acknowledged, but not operationalized. So what are the main findings of this particular chapter? What I want to emphasize for the younger generation is that we had some of the seminal documents of the women's movements, such as the Shram Shakti report. It was far ahead of its times in terms of its recommendations. So even in 1988, it emphasized measures such as training of doctors in occupational health and safety, research and training in ergonomics, apart from saying schemes for provision of drinking water to every home, making fuel available to all households. So they were actually trying to say you don't just address the ailment, but you try to prevent it by providing some of this basic infrastructure. So I think the Shram Shakti report is far ahead that, and we're still addressing some of this in project mode through some of these particular programs on giving gas cylinders, Ujjwala schemes and all of that. Okay. The second important finding I feel is the report of the Second National Commission on Labour, which included the late Ela Bhatt as member. And there's a very interesting section there, which is on labor administration, which is generally never covered in many of the labor reports. And what is categorically admitted as late as 2002, that the institutional mechanisms to implement and monitor the operations of the then existing legislations relating to health and safety of workers were either grossly inadequate or yet to be created. Now, it is from this particular report that I came to know that we had one of the very organized Directorate of Mine Safety, for example. Mining is a very important activity in our country. And we had this Directorate of Mining in the country right in 1951, right very early on in the 50s and 60s. They had recommended a set of people who were to be appointed. And what Ela Bhatt is saying in 2002, that the number of people who were supposed to be appointed in the 50s and 60s have still not been filled up in even as late as 2002. And that is the status of the labor administration in the country. So that is something which I thought needed to be highlighted. Because if you don't have the administrative personnel, nothing is going to be monitored and nobody is going to be accountable. Some illustrative, what I've done is I've taken a number of several sectors that covered in this thing, but I'm going to only illustrate one of them for you to for all of us to understand what exactly I'm trying to do when I say revisiting unresolved issues and also examining new challenges. For example, I'm taking the mine and quarry workers. These health issues relating to health and mining, mining workers have been extensively covered by the Second National Commission on Labour, and it singles out Rajasthan for the sheer number of mine workers and documents that about 72% of mine workers complain of one or the other respiratory tract infection. So it covers extensively legal, illegal mines, number of men, women, children, all of them working in these particular mines. And but for the sheer number, Rajasthan has been covered, and several diagnostic studies have also been mentioned in the Second National Commission on Labour. Now, if you fast forward to the present, Rajasthan still leads in numbers of mine workers. Now, what has changed between then and now? Now, what is new is the sheer number of workers in illegal mines, of which there is no count. Many articles also point out the politics of misdiagnosing silicosis as TB and of the resistance among doctors to acknowledge the evidence of silicosis and notify the same. So the politics of the entire thing is extremely important for us to understand that if you misdiagnose silicosis, if you say you have silicosis, then you're bound by this thing to give some kind of redressal to the worker. So what you do is that you don't admit, doctors don't admit. So we have a big this thing to be done with the doctors. They misdiagnose it as TB, and the fine for not pointing out or not reporting silicosis is only ₹50. So everybody pays the ₹50 and gets away with it. Okay. The penalty for not reporting the disease is a mere ₹50. Most women and children work in illegal and or abandoned mines such as mica mines. Now, why do they work in the mica mines? Because mica is very essential for the cosmetic industry. There was a global outrage, pointing out how the cosmetic industry is using men and women. So for some time there was some noise about how we should, about all these clauses and everything about not employing child labor. But we are back to square one. We have a large number of women and children working in this. So I've only taken the illustration of the mining industry. I have done similar exercises for leather, for BD and cigar industry, and all of that. So I've said what happened then and what is happening now. Now I've had just one sec. I'll do it fast here. I've highlighted the current occupational health status of BD, leather, and salt workers. Now, why did I single them out? Because these are industries which fetch a lot of foreign exchange for the country. And what you find is that not much of it or hardly anything is spent on workers' health and so on and so forth. So most of them are informal workers and don't get any benefit out of the foreign exchange that is done. Now, the labor code relating to occupational safety and health and working condition appears to have been instituted to safeguard the interest of employers, in that it does not specify even minimum standards for occupational health and safety or daily or weekly working hours. Now, by laying down a threshold of 250 for instituting a safety committee at the workplace, it mocks at the 90% informally employed workers of the country who are either self-employed or work in smaller establishments. And my last point is politically affiliated trade unions registered under the Trade Unions Act have equally failed women workers. I have elaborated on this. I can elaborate it with this question, but I think my time is up. Thank you very much, Nidhi.
Thank you so much, Padmini, for finishing right on time. When you for all the participants here, when the report is out, we will share with all of you because we have your email IDs with us. So be assured that we will share the report with you. But Padmini's chapter is really very interesting, and you can imagine like 50 rupees penalty for a doctor is something like laughable, but we have to move on to the next presentation. So I would now like to request Sandhya, and she will talk about both the infectious diseases as well as the non-communicable diseases from a gender perspective. You can begin, Sandhya. You have little more time, around 14 minutes. So 13 to 14 minutes.
Okay. Yeah. Well, I think I will, I tend to speak fast, so I might be a little shorter than that. But anyway.
You can take it.
I can't slow down. Okay. So I just wanted to say I'm speaking on the gendered nature of disease control programs. This covers 2 infectious diseases. The section on HIV written by Jashodhara, on tuberculosis written by Amita, with a case study on malaria and pregnancy. Then I cover briefly a couple of non-communicable diseases covered by the NCD program, which is cardiovascular disease, diabetes, respiratory diseases, cancer, and mental health. And there's a section on gender dimensions of caregiving written by Asha Kapoor Mehta. Now, I'm saying all that because actually it was difficult to pull the chapter together. So what I'm going to do is I'm just going to identify a few of the challenges and barriers identified in the course of this, flagging a few issues for others to think about. Also, a number of the points we raised earlier, Ravi laid down sort of the background in which the healthcare system is functioning. Deepa spoke about nutrition and how it affects women. Padmini spoke about occupational health and therefore how it affects women. Having said that, and speaking, one of the issues that came up was that women have biological vulnerabilities. For example, coronary vascular disease, the risk is much higher in women. It goes up after they reach menopause, but it is harder to diagnose in women. And the tests that are there right now are less accurate, and there is less suspicion of for a heart attack, for example, if a woman comes in. Now, in case of TB, extrapulmonary TB is much more common in women, but the symptoms are non-specific, and the high-quality lab tests required are not universally available. Asthma is more common in women the reproductive age than in men, more severe. Women with TB, malaria face additional risks in pregnancy. Women who develop diabetes in pregnancy risk developing diabetes later in life. So these biological vulnerabilities require specific interventions or modifying diagnosis and treatment protocols. There are social vulnerabilities that people have spoken about, work conditions that put women at greater risk, such as solid fuel burning indoors for COPD, various industries, we're working in the garments industry or beady rolling for tuberculosis, as Amita points out, as Padmini also laid out a little earlier. Unequal gender power relations that put women at risk of HIV in the course of negotiating safe sex, gender-based violence. In the section on mental health, what came across as really striking was the spousal violence is an independent risk factor for suicide. In fact, gender-based violence drives the entire mental health issues as far as women are concerned. There's a greater prevalence of undernutrition, as Deepa points out, affecting the risk of, for example, tuberculosis. And there's reduced access to resources in government programs. A small illustration is that just the government is supposed to supply insecticide-treated bed nets, okay, specifically for pregnant women, if I remember correctly, but they get cornered by either older family members or male family members. In the context of treating public services and growing private sector, there are various gendered barriers to healthcare. Women may give low priority for their own healthcare as opposed to their care as their role as providers. Women may have a lack of autonomy in to spend money on their own treatment, which results in delayed treatment or no treatment. For example, breast cancer, which is the leading cause of cancer in women, is routinely diagnosed as stage 3 or stage 4 in India, with a very, very low rate of 5-year survival. Thirdly, women cannot count on social support. They're reluctant to report domestic violence. Women with mental illness fear abandonment. And the stigma of, for example, tuberculosis and HIV affects health-seeking behavior of women and prevents timely testing or treatment. At the same time, that women have less access to care. Caregiving is a woman's work. It's unpaid female labor. While women face barriers in accessing healthcare, they usually are the primary caregivers when a family member is ill. Their work is unpaid, not recognized as productive work. And it may force girls to give up their education, force women to stop working outside the household. In the case of HIV, women may be held responsible for the husband's disease. And when the illness is prolonged or when the costs of care go up, which happen in the growingly privatized sector, family members and friends may distance themselves, leaving women to bear the financial and other burdens of caregiving alone. A couple of illustrations, gender and TB kind of, the section by Amita on gender and TB illustrates kind of the challenges of the system itself, the way it functions. Women face greater attrition from tuberculosis diagnosis to treatment completion because of the reduced autonomy and their role as caregivers of others. They must navigate poor healthcare infrastructures, difficulty in access to care, and lack of coordination between the MCH, HIV, and TB programs. Stigma and shortage of women women staff in the program send women to the private sector, leading to interrupted or ineffective treatment. And finally, the financial barriers faced by women in remote areas includes the cost of travel, diagnostic, and treatment charges, all of which make it much more difficult for women to access TB treatment. Trying to identify key things in different programs. In HIV, what came across to me as really striking was the fact that the laws aren't implemented. There are very progressive court judgments, not always translated into law. For example, negotiation of paid sex work therefore becomes done covertly to avoid the police, often preventing negotiation of safe sex. And the Transgender Act 2019 decriminalizing this transgender community hasn't been implemented in any meaningful manner, which would have actually reduced the harassment that transgender people face and the stigma. One essential component of the programs is screening. And what you see in the programs is one, unethical screening, and two is ineffective screening. So, for example, the household sample survey uses bio-behavioral data from pregnant women without their counseling, without their consent, without counseling. And the test records can be linked back to the women in case they test positive for PMTCT treatment. But the point is it's done without their consent. Another thing which is not in what I wrote was that the National Sickle Cell Anemia Elimination Mission, which is being conducted in high prevalence districts, is conducting universal screening without counseling and issuing sickle cell genetic status cards. Okay, completely illogical, unethical practices. Married women are abandoned by their husbands. This is something that was discussed at Sama seminar last week. That's unethical, ineffective. One example of ineffective screening is that, or not happen, screening is not being done. Now, breast, cervical, and oral cancer make up the bulk of cancers in women, but less than 2% of adult women have had screening for breast, cervical, or oral cancer, less than 2%. Another example of what happens when women are forced into the private sector because the government sector is not functioning well. Diabetes drugs are often out of stock in government centers, inevitably forcing patients to spend money for them or to do without or to ration it. And the people who bear the burden, therefore, are women with diabetes. So women with diabetes in India get fewer essential treatments, less aggressive treatment, less monitoring for compliance. Likewise, because because something like 40% of cancer patients are not covered by any government schemes that are available there, this forces patients to spend out of pocket, and women are less able to spend. And in fact, the cancer program sort of illustrates very well exactly what women experience here. Cancer is the leading cause of out-of-pocket expenditure and catastrophic health expenditure on health. Cancer followed by CVD. Now, cancer in treatment, even in government centers, entails considerable expense, and drugs are a major contributor to this. And the consequences, straightforward: men are more likely to go to private service for care. Okay, they're more likely to spend more money, spend beyond what they can. Childhood cancers, actually, the incidence in certain childhood cancers, incidence is the same among girls and boys, but boys are more likely to get diagnosed and to get treated. The further the distance from the services, for example, the less likely a girl is to get treated, because parents may be reluctant to bear the cost of travel, treatment, etc. for girls. And it's not just about the money, because, for example, parents may refuse procedures for girls, procedures which are disfiguring, such as amputation. Finally, just concluding, the entire NCD program is based on screening and counseling, treatment for what are called lifestyle risk factors. Now, the major risk factors for CVD, diabetes, and cancer are obesity, inactivity, and tobacco use. And strangely enough, I don't understand this. I don't understand how women are more likely to be obese. Women are more likely to be inactive, but that seems to be the argument. The NCD program screens for risk factors and counsels or refers for treatment. It does not address the context of such factors, such behaviors, the lack of control over food choices, working conditions that rule out healthy physical activity, the reasons behind the use of tobacco, for example, and all the constraints that people face, and in particular women face, in addressing these. Thank you. Was that in time?
Yeah, very much in time. In fact,
Okay.
you have few more minutes with you.
That's
But thank you so much for sharing. And just to add, like the chapter also talks about the whole gender bias in the research around the non-communicable diseases. Like these are the diseases where government has recently started focusing. So there's hardly any data around that also. And one more thing, that in most of the chapters, wherever possible, the authors have tried to integrate the concerns about the transgender communities. But like some of them have already said that there is a lack of gender-related data, but some studies done with these communities have been definitely, so those aspects have been covered. And in terms of women and the obesity, because you have like 1 minute is still there. So the thing is, because of the care burden, women are not able to follow the lifestyle in terms of like even eating on time. And some of these irregular eating timings, lack of sleep, and all these are the ones which actually are more nowadays considered to be responsible for obesity rather than the food intake. So food intake not in time is a major issue. So yeah, and sleep deprivation is another issue given the workload that they face. So possibly, but more research is required for sure about
Exactly.
the
Yeah.
non-communicable diseases. Yeah. So from here, now we move on to the reproductive health part. And I would now like to request Rashmi to take us through the concerns, reproductive health concerns across the life cycle.
Yes. Hello. Can you see my screen?
Yeah, it's visible.
Yeah. Yeah. Okay. Yeah. So the advantage of being the last speaker is that most of the examples and most of the issues that we have covered in our chapter are already discussed by the previous panelists. So that's one good thing, that's one background to what I'm going to say today. So even though I'm going to present these findings, the chapter is written by me along with two of my colleagues, Nilangi and Renu. Both of them are here today with us. And yes, I'll start. Yeah, sorry. Some technical glitch. Actually, I'm getting a message with unstable internet connection. That's why I'm not switching on my video right now.
No problem. We can hear you very well. So
Yeah.
you can speak without.
Yeah, great. Okay. Like Nilangi said before, reproductive and sexual health issues are discussed the most when it comes to women's health. But at the same time, there are so many issues in access to some particular health, reproductive and sexual health aspects of it. We have covered all these in the chapter. We have actually used life cycle approach to analyze the sexual and reproductive health issues. That's because there are when we look at different stages of women's life, there are some commonalities, and at the same time, as the age varies, as the women age, we also see some peculiar issues that are specific to their age, their marital status, and these things. In terms of commonalities, for example, the unpaid care work that uh, the previous speaker has also talked about. The involvement that in the unpaid care work that starts during childhood while taking care of the younger siblings, it continues through the reproductive age group, caring for elderly in the family, and for the elder women, it becomes the spousal care as well as care for the young children in the family. So that's and given all these things, the access to healthcare for them, for their own health, it's hampered somewhere. So that is why we have considered life cycle approach. At the same time, as we progress, we are also talking about during childhood and at the time of birth, the sex ratio at birth, child sex ratio, there is a clear male preference, and we can see that the child sex ratio is low. And as the women age, when we are talking all about the elderly women, because of feminization of aging, because of different biological social factors, we have many women in the older age group, and the issues they have are very specific. So that's why we have considered all these different stages. At the same time, we have also focused on gender and equity perspective. That's because health indicators, access to access related indicators are affected by biological factors, social factors, economic factors, cultural factors. So for example, the proportion of girls in 15 to 18 years of age who have begun childbearing, so that indicates early marriage, child marriage. If you look at the data, I'm not going to present the data, but just to give one example, if we look at economic classes from highest quintile to lowest quintile, you can see that it progressively increases. Also, the access to hygienic methods for menstrual protection, especially among the adolescents and the young girls, it depends on several different factors, including residence, if they are in rural areas or urban areas, if what is their education level and what is the economic class of the family. So that's how we have actually structured our chapter. We have given these differences across these different groups. So coming to the access related issues, so even if we say that when it comes to women's health, it is reproductive and sexual health, that reproductive health that is given the most importance, but still we have issues related to lack of access for some particular health issues. For example, access to safe abortion. So despite having law on abortion, accessing abortion services is a challenge in India, and we have covered that in the chapter. Also, when we are talking about contraception, so in contraception also there are huge variations across different states of India. The demand for family planning that is satisfied by modern contraceptive methods, it differs a lot across different states. So that's what I'm talking about. Also about reproductive cancers, it has been mentioned by Sandhya before me. Diagnosis at a later stage and inadequate treatment inadequate treatment leads to a lack of access for these particular health issues. Given all this, irrational care is also rampant when it comes to reproductive and sexual health. So we know two examples like hysterectomy and C-section. So median age for hysterectomy in India is 34.6 years. And the cases of sugarcane cutting women undergoing hysterectomies because of the pressure from their employer and not to miss the productivity on the farm. It is well researched, it is well documented. Also C-section rate, which is very high. 22% C-sections are reported in India, and it is much higher than the 10 to 15% of what is expected. But at the same time, the inequities based on different social and economic groups. Yeah, I'll finish in 1 minute. The inequalities based on these different social groups, for example, C-sections in private health facilities, urban areas, C-section among women with higher levels of education. So these are also presented in the chapter. Yes, so about knowledge and information related gap, the status of comprehensive sexuality education, we know that there is ban on comprehensive sexuality education in many major states, and the main source of information about sex, sexuality is peer sharing, non-formal education. So these things are also there. Lack of counseling services for adolescents, for women in the reproductive age group through RKSK, through VHSNDs, that is also well known. And despite having a national policy for elderly and various schemes focusing on them, social security schemes related awareness among elderly is also very low.
Last minute.
Yeah. And coming to my last point about quality-related issues, this has been covered even before in terms of the inequities we have. So for the better quality health services are concentrated in urban areas, affordability and of better quality services, that becomes an issue. Also, while we are talking about maternal health, which is at the center of reproductive and sexual health in India. While there are mandated ANC visits, there is good access, but when it comes to the quality, it's only 1 in 5 women who have reported that the quality was also optimal. So yeah, I think I'll stop here. Yeah, thank you.
I'm really sorry for cutting you, because I know this chapter, this is one big chapter, and because we have put both like for big for adolescents, for women in the reproductive age group, and postmenopausal women. So it has quite a lot of issues to be covered. So I had now here we have actually finished all the presentations from the authors. So the idea behind this webinar is to just, one is to share that this kind of work is underway and it will be soon finalized and the report will be available. But we are going to have like this series of webinars. The other sections will also be covered in subsequent months. So once all the webinars are done, we will share the report. So because I saw many chats asking about when will the report be available. So maybe another 2 or 3 months, the report should be out. Now, actually, after the presentations by the authors, we requested actually 2 discussants. So first, Devaki is going to speak. I will introduce her in some time. But I had one request for all the participants, that we have allocated around half an hour for the discussion around the questions that you have. So please feel free to post the questions in the chat box, and we will the panelists will answer those questions. So it's my pleasure to welcome Devaki as a discussant. So I'll introduce Devaki. Devaki Nambiar is a health policy and systems researcher with an interest in social inclusion, health equity, gender mainstreaming, and the right to health, with a focus on equity and inequality in health systems for populations with historical disadvantages, such as homeless persons, cis women, and others. She has also co-facilitated regional and national courses and trainings across WHO regions on health equity, gender and health, as well as health inequality monitoring. Welcome, Devaki, and please share your valuable inputs.
Thank you so much, Nilangi. It's a total honor to be here on this occasion and to be able to speak to you all. I had the privilege also of seeing a draft version of these chapters in this section. So I'm informed and really energized by what I have read. It's a very exciting compendium of information and a very particular and important lens. So I share the enthusiasm of participants here with respect to this report. I'm speaking in my personal capacity, actually, and I think for me, this opportunity allowed me to reflect on 3 types of messages, which I will try to fit in about 7 minutes. That the chapter gets into. And I think the core message is just the very easy and marriage and compatibility of neoliberal capitalism and patriarchy. Okay. And the section really abounds with examples of this. And if I can attempt, I don't have an economics background or a financing background, but if I can attempt to use some of that terminology, I will try. And then you all can critique me on that, please. But you see, with respect to gender and health systems, the simultaneity then of unwanted attention, where there is attention placed on the bodies of cis women and trans women and sexual and gender minority populations on the one hand, and the lack or deficit of needed attention, what is wanted, right? So there is a surplus of unwanted attention and there is a deficit of needed attention to gender-related issues. And like I said, the chapters abound with examples of this. And if I can just start by borrowing some of Deepa's framing, she even had a slide on this. The very many roles that, take the example of cis women playing in the health system, as sort of rights holders or as users or beneficiaries of health systems and of health schemes and policies. You see the deficit in terms of the needs, the actual felt needs that women have. Rashmi talked about the vexed nature of abortion access. There's the issue of gender-affirming medical interventions for other populations. There's some mention of this in the report. There is what Sandhya mentioned, the lack of consent when procedures are carried out. So just this sort of lack of attention to the needs and the lack of care of how services should be delivered. At the same time, you see a surplus of a different kind of attention, of marketing, for example, of substitutes for breastfeeding by the corporate sector, a neo-Malthusian sort of argument and focus on controlling women's bodies and on forced sterilizations and things like that. The picture with hysterectomy that Nilangi, you yourself have worked on, that is also very, very vexed, where there is this desire to just get the uterus out, and women let down by the system, let down because of this deficit of access, also being persuaded to have early hysterectomies. And taking that surplus attention and having to struggle with that and the aftermath of that, which is also described in some of Sandhya's writing in the chapter. As workers, Professor Padmini talks about this also. There is this deficit of recognition. There's a question actually about salaries. There are massive salary discrepancies for women workers in the health sector and outside of the health sector. This has bearing on health and what you can buy to stay healthy and what you can afford. At the same time, there is a surplus of responsibilities for providers or women workers in the health system by way of tasks, by way of needing to negotiate technology, reporting, even occupational hazards, as Professor Padmini was laying out for us. There is a surplus of those burdens, right? And when you think about carers, which Deepa also importantly acknowledged in today's presentation, there is a deficit of resources. There is a deficit of recognition of the work of caring that Deepa also pointed out. At the same time, there is this surplus of the different types of responsibilities that one has to take up, and the costs that are associated with this. So Sandhya also talked about the deferment of care, foregone care, simply because you are a caregiver, you don't have the time, you won't be able to do it yet. And in any case, you don't have the money to do any of these things. So that, I think, is very striking in this chapter and quite stirring for someone to look at. A couple of points that are sort of implicit in the chapters that I just wanted to raise that point to some of the other literatures that I've been looking at. I'll get to now very quickly. I think there is something here also about the accumulation of the burdens, of the surplus on the one hand and of the neglect and deficit on the other over time, right? And so there is some treatment in the chapter, in the section, on the intergenerational burden that this creates. And there is something called the weathering hypothesis that has explored this in the context of racism in other parts of the world. And I would venture that something very similar is happening to sexual and gender minorities in India, where the weight of that discrimination, the stress of that, and in fact, there's even a biological analysis of this by way of the term allostatic load, the sheer accumulation of stress, the amount of stress you have to carry in your bucket, changes then physiologically your health. And weathering changes across a period of time and across generations, the ability of women, their daughters, and their daughters to be able to navigate, negotiate the health system and to stay healthy, or even to manage their illness when they get ill. So there's this sort of piece of accrual that you're seeing of ill health in this context that is truly deeply gendered. Relatedly, a number of our speakers have talked about the policy response to this, which can be characterized as stagnant on the one hand, or neglectful on the other for the most part. And I think there have been some well-intentioned efforts to bring about policy change. But as Deepa showed, the funding for these has been stagnant at best over a period of time. And in other cases, as Professor Padmini laid out with the labor scenario, nothing has been put in place. As she said, with the labor administration piece that that Ila Ben had mentioned, it's just not there. I'll end very quickly now, Nilangi. I see you're back. So what is to be done? 1 minute more for solutions. That's the other thing we do. The problem diagnosis, and then for solutions, we're like, brrr. But anyway, here are some thoughts that I had on this, and I see inroads into this in the chapter, and I'm very excited for everybody to read it and ask questions. The first is to just break these binaries. We've already talked about the gender binaries, but also binaries of surplus and deficit. I have a report here that I'm going to put up for Rashmi to share with everybody. But we really need to contest growthism itself and the idea of surplus and deficit itself, right? We need to think about circular economies, about degrowth, about different economic models that visibilize and actually challenge this love relationship between neoliberalism and patriarchy, right? That is helped by solidarities across generations, as we have mentioned. Professor Padmini, Dr. Ravi, they have talked about these historical legacies that we really need to be connected to, that generations like me really need to sort of hold and see how to take forward. And really the silos also that Dr. Ravi was talking about in those early days, right? We need to think past that. I think there's something about poking holes in the system, both from inside and both from outside. The feminist movement and women's rights movements have done a really good job of this so far. And, you know, everybody's tired, everybody's weathered out, right? But we do have to keep going with that from all directions possible. And that's important. And finally, I think there's something about transparency and ecologies of knowledge. Sandhya, I think you got into this, but I lost power. So I hope I'm not totally rehashing what you said. There is a need to really enhance our understanding of the sex, to have more sex disaggregation in our data to begin with, to visibilize knowledges and experiences of sexual and gender minorities in the first place, and to demand that accountability from public systems by way of data, by way of research, and more. I'll stop here, but it's been very exciting. I look forward to our discussion.
Thank you so much, Devaki. In fact, Devaki and Rajalakshmi, these are the two people who are outside the group who got the opportunity to go through the report. And for us also, it was actually good to hear from Devaki. And we will have a Q&A session, and then we will hear from Rajalakshmi as well. So thank you so much, Devaki. Very beautifully, you have actually sort of put together all the chapters in a common framework, and so thanks a lot for that. So I will now hand over to Jashodhara, and she will actually moderate the Q&A session. Over to you, Jashodhara.
Yeah. Hi. So thanks so much, Nilangi, and thank you so much to all the panelists and to our first discussant, Devaki. I think it's really valuable to hear your take on what everyone has been presenting. And we would really like now to go into a little bit of a question and answer. So the first question that we had was one participant wanted to actually learn a little bit more about the gender pay gap. So I'm going to give Padmini a minute to go into that, and then I'll just look at a few more questions. Padmini, over to you.
Yeah. Let me, I mean, it just said gender wage gap. So I was just trying to understand what about the gender wage gap that we are talking about. For example, if you're comparing the way I have studied or the way things have, I have understood gender wage gap is, for example, in the industry after industry, we know that the manner in which units, sectors and units, the manner in which they kind of demarcate tasks. So you find that in collusion with the employers, in collusion with trade unions or any of those, they demarcate tasks in such a manner that the tasks that women end up doing generally get less pay. They're also termed as unskilled or semi-skilled, and therefore they are paid less. But if you ask the employer, they say no, the women are doing these tasks, and that is the wage that has been agreed upon, and that is the wage gap, this thing that we have. So many of these industries, for example, the garment and the BD industry and all of that, now many of them are outsourced. They are also home workers, so they actually have no negotiating power about how much the contractor actually pays them. So it also goes by how the contractor decides how many this thing that you have to do, and that there is nothing to compare because the men are not holding the BDs, or the men are not stitching the garments, or the men are not putting on the sequins of the garments and all of that. So there is nothing that you can compare with when you're doing that. This thing. It's just that women are being paid very low, which barely covers their expenses or which barely meets their needs of the family. Now, in mining and all of them, you find that many women and children are in what is called as the mines themselves are illegal. So they are so you cannot negotiate on anything that is given to them by the this thing. So no, there is no official body there to say because the mines are illegal. And if you now want to regulate that, it's an illegal thing. It will be disbanded, and the women lose whatever it is. There is no alternative this thing to be done that. And the last point I just want to say, Jasodhara, is this, that there has been studies using the data that we have available, the what you call as the periodic labor force data. Now, in that, if you find the comparison that you do, a very highly industrialized state and a developed state like Tamil Nadu, that the gap between the genders is highest in the country is that. But the women are getting more paid than, say, Bihar or Orissa or whatever it is. But within Tamil Nadu, the gap between what the men get and what the women get is very high. And as one of our scholars has said, it is the highest in the country. So I think what we need to do is to understand how to work out these kinds. If you compare Tamil Nadu with Orissa and all of that, we always come out smelling like roses, right? But you need to compare Tamil Nadu with Tamil Nadu 10 years back or whatever it is and see where the women, and the divergence is very, very high. I'll stop with that.
Thank you. Thank you so much, Padmini, for all your valuable additions to the conversation. So we have a number of questions. Of course, several questions are related to the report itself and whether, it's possible to read it, and also whether it's possible to collaborate with the people here. So just for all the participants and attendees, I would like to say that we would love for you to collaborate. Please get in touch with our secretariat, which is at the Feminist Policy email, which I think must have been, available to you. Otherwise, I would request Airman to please pin the email of the Feminist Policy Collective on top of your chat. And people can actually directly write to us if they would like to be engaged in future collaboration. So I'll just come to some of the questions that have been raised. So one of the questions was that, did the report explore workplace harassment within occupational health? And we are actually just, the question has actually been answered in the chat box, which is that the section which is on gender-based violence and sexual violence, that actually has a substantial section on the harassment in the workplace. Now I'll come to some of the other questions. So does the report look at problems faced by women health workers, doctors, nurses, and others? So this question could be answered either by my co-author Ravi or myself. And then there are questions about the challenges with gender disaggregated data. How did the researchers navigate this? And what are the limitations of the report? So perhaps, Nilangi, maybe you as the anchor could respond to that. There is a question about transgender issues. So once again, I would expect Sandhya to reply to this. But just to explain that a lot of transgender issues have also been covered in the section 4, which is on violence. But Sandhya, you could speak to this as well. Then there is a question of there is a level of awareness on assessing the health of several other, gender issues like transgender health, post-abortion and postpartum care, menstrual health, etc., and having to be away from the forefront, etc. So what would be a more inclusive way to work on the health system? Then there is a question which Dr. Iqbal also wrote about whether or not we have enough focus on the wellness centers and to what extent they might be curative centers. So this I would ask Ravi to actually respond to. So I'm going to ask our panelists to please take not more than 1 or 2 minutes, please, in order to keep to time. Can I ask Sandhya to please go first? And then Ravi and Padmini, there is, I think, one more for you. So we'll come back to that. So Sandhya, please go ahead.
Okay. What was most striking to me was there's very little knowledge on medical treatment relating to transgender people. And the one example that was striking was that of diabetes, both in terms of the hormones that might be taken by a transgender person during transition, or a person with diabetes. What are the hormonal issues to be faced by personal diabetes? It's a very biological, medical kind of approach. But what is striking is that there's very little discussion on that in what I read. And just a couple of mentions in some papers and technology, that seems like at one level it might seem like a very minor thing, but I think something that will affect every single transgender person approaching the health services. That was most striking to me. The second point would be about the law. The fact that the section on HIV said that whatever laws that do exist aren't implemented, resulting in some kind of criminalization of behavior. But again, what's striking to me was really about provider knowledge on the subject.
Sandhya, there's just one more question, if you can quickly respond to. Lakshmi said that she couldn't hear what you said about bio-behavioral something. Could you just quickly respond to that?
Sure. Actually, that was to do with your piece, Yashodhara. What you said was that in screening, that bio-behavioral samples were taken from pregnant women, which could then be tracked, could be linked back to their HIV status, could be linked back to the individual in order for them to access treatment, that is mother-to-child transmission, prevention of mother-to-child transmission treatment. So that was the issue, as I understood it, that part of that this is a routine screening practice in the household health survey, if I remember correctly. So the point being made was that screening is being done without counseling or consent. And the positive part of that is that women who test positive can get access to treatment, but they have not been counseled in advance of this possibility, and their consent has not been taken for this. Does that make sense?
Yeah, thanks. And Mridul has commented on the palliative care issue. Okay, Ravi, would you like to take the next couple of minutes? Please go ahead.
Yeah, thanks. As regards the question on problems of health workers, yeah, partially we have looked at a separate section on health human resources, which actually Yashodhara has done. So she could add to that. Our health human resources, the paramedic workforce is largely women, and many of these women are not paid proper wages. So that wage issue is definitely there. Like the health workers, for example, are given some honorarium, and it varies a lot across states. So the wage issue is there. I mean, the amount of time they spend virtually full time. They're called volunteers. So no social security and so on. So these kind of issues have been discussed, but it has not. We've not gone into details of the kind of problems faced by health workers because the mandate was limited. As regards to Iqbal's question, I think he's raised an important question with regard to how the health and wellness centers, whether they are bridging the gap. See, Iqbal, the health and wellness centers, actually, that whole concept came in because of the sub-centers and PHCs were largely focusing on preventive and promotive health care, and the curative care was a weaker component. Kerala is a different story because of the large, strong historical kind of primary healthcare system that has evolved in Kerala and a few other states. But generally, you find that the curative care component is very weak. So the health and wellness centers are supposed to provide a mid-level provider who would actually have better training in dealing with non-communicable diseases. So this is basically to strengthen curative care. So this is how the policy kind of looks at it. But the approach is, or should be, as I said, should be comprehensive primary health care. We do not want to create another silo or a segmented program where the health and wellness centers become only curative care oriented. So I think Kerala has a good is a good example of closer to an integrated healthcare system. It has seen its ups and downs, but I think it's a good example to follow.
Yeah.
And yeah, thanks.
Yeah. No, Ravi, please complete what you were saying.
No, I think these are the two questions. There was also a question on the Ayushman Bharat PMJAY, whether disaggregated data is available. There's very little data available. Some of it we have referred to in terms of male and female kind of utilization for different ailments, but we see less and less of data being there in public domain. In fact, if you look at it now, I mean, they virtually kind of closed down the public access to data, and whatever comes out is what the Niti Aayog kind of brings out as newsletters or something, some information from time to time. But the open access which we had during the RSBY regime is gone. So, definitely there's a data gap, not only gender data, but even otherwise.
Yeah. Thank you so much. I was just going to add that question for you, Ravi. So this actually gets us a really good segue into the question of data. And Nilangi, do you want to just quickly say a few words about the challenges and what was the strategy that this group adopted in trying to come up with a conceptual framework? Thank you.
So basically, when we were conceptualizing, one part of it was that what is currently available in terms of policies and programs. So one was the feminist critique or the gender-based analysis of the current policies and programs. So looking at the design issues. Then when we came to the implementation, this question about the gender disaggregated data became very important. So there were two ways. One, like Ravi said, the access is also limited now, and Deepa in her paper has also said that. So we don't have the comparative data now to say that how whether the situation has worsened or improved, because government is changing the names of the schemes, the way data is being recorded. So it's difficult for comparison. So wherever available, we have taken like NFHS for the reproductive health thing, so that we can compare across the 2-3 rounds like NFHS 4 and 5. And wherever possible, we also looked at, for example, in our paper, we looked at the performance audits of the CAG, which is slightly, I think, sort of independent source apart from what Niti Aayog is putting out. So looking at those reports by government, and then in addition, the studies done by other other researchers. So this is how we looked. So conceptualization, I will say that it was basically the critique of the design, the critique of the implementation. These were the two main aspects to it. But definitely in terms of gaps, when we talk about the gender diverse communities, the lack of data is a major challenge, because then we have to only rely on the studies which are there, and we don't have any actual numbers to talk about the situation. However, the additional concerns of these groups have been, the authors have mentioned them, but surely this was a major challenge, and others can also add if they want in this to respond to this.
Thank you, Nilangi. Yeah, I think one of the things that we wanted to also focus on was to look at an analytical framework of using a feminist and intersectional lens, because not just trying to set out, this health condition affects women more, this health condition affects men more, or this health condition affects non-binary genders more. It was not just about setting out the incidence of various health conditions or health needs, but it was more about analyzing from a feminist intersectional lens how we can look at policies, plans, and budgets for these, and where are they falling short of being gender transformative. I think that was really our lens, and we had to deal with this very real challenge. So in the chat box, Dr. Iqbal has made some very good comments about the situation in Kerala. Thank you, Dr. Iqbal. And there is also a remark about the distribution of sanitary napkins in Kerala. So just asking whether this was part of our study. And I would just like to clarify, the India Gender Report is not a study. It is actually a compilation of available scholarly work, research, data, and whatever findings are available, even within civil society groups, to compile them and to provide a feminist analysis of what this tells us about the gendered nature of health policy making, and of course, other kinds of policy making in the other sections. So we have not actually gone in to study specific issues in specific locations, but we are more doing a kind of review of studies. Nilangi, do you want to also respond to that? Yeah.
Oh, I just wanted to remind you about the time that we are almost towards the end of the Q&A session.
That's right. That's right.
Yeah,
yes. Okay, I thought you wanted to add. Okay, so anyway, I'd like to thank everyone who has written in with questions and comments, and thanks everyone who has expressed their appreciation of the panel. The credit goes entirely to the panelists and the discussants so far. And now I'd like to welcome our second and last discussant. That is Rajalakshmi. And Nilangi, can I request you to briefly introduce Rajalakshmi? Hi, Raji.
Hi. Just say.
Okay, no problem. Nilangi, can you just provide a brief introduction? Thanks.
Yeah, welcome, Rajalakshmi. Yeah. So TK Rajalakshmi is the Chief of Bureau, Delhi Frontline, and she has spent 25 years in journalism, writing on a gamut of issues covering the social and political and the intersectionality between the two. And her interests lie in examining policy decisions pertaining to the social sector, gender, health, education, and the politics that drives policy. So welcome, Rajalakshmi.
Hi, thanks for having me here. I think there's not much to say after hearing all the rich papers that have been presented, and the perspective in them. I think one thing which is common is that all of us share a certain concern and are sort of concerned about the way things are going in this country, and therefore such kind of initiatives are important to critique policy as it exists, to review review new policy as they come about, and yes, to examine issues of access, equity, gender, which is which I think runs through, as a common theme to all these issues. And if one, in fact, feels, somewhat cynical that things really haven't changed so much. I mean, ever since in fact, 75 years or 76 years, of our independence, and we are still sort of talking about issues of access. We are still talking about issues of equity, and of course, the sorry state in which, women find themselves in, if it is, for instance, with respect to nutrition, their status of nutrition, their status in terms of workers, their status in terms of equal, participants, in decision making at homes. So I think at some very fundamental level, I think all of us feel, a little bit dejected that we are still continuing to speak of the same things that we did at the onset of of neoliberal policies, the entire thrust towards privatization, which has increased, in manifold terms. We see how certain groups, continue to be excluded because they're just not considered. They are on the margins. They are economically, socially on the on the margins, and plus the added factor that they happen to be women, and belonging to those marginalized groups, economic and socially excluded groups, that it becomes a double kind of punishment. So I think Ravi Dugal's paper, along with Jashodhara, it I think sets the context for the entire for this entire webinar, where essentially he says that that the system has to be addressed, and that public and that the public has to be brought back into discourse. It can't be left to the private sector at all. I mean, the way things are, it can't be left to the private sector. And of course, since he also speaks about the evolution of health systems, and there's a historical understanding, the slow withdrawal of the government. I mean it's shocking to learn that the government in fact was not even willing to finance the Bhore committee. I mean, that is something that I didn't know. So I think some of the papers really, in fact, highlight things that also need to be known and need to be talked about. And then we have Deepa's paper, for instance, is I think she speaks about the state of course nutrition, and that with growing age, the nutritional discrimination increases. So that's again a thing to be studied. I mean, as to why does it happen. Again, she also expresses deep concern about declining budgets, declining finances for ICDS, MDM, etc. And of course, this entire contradiction, that women are addressed, but they're addressed as targets, which Ravi Dugal also makes a point, and it also resonates in all the other papers. And then the entire issue about how the healthcare workers, who are women essentially, how their needs are completely sidelined. For instance, the ASHA, USHA, or ICTS workers do not even get a pension. They are in fact not even considered as employees of the government, though every other government scheme they are expected to implement. Then of course, I really don't think it would be fair for me to sum up, for instance, what all the richly detailed papers have. But I'll just say that in Dr. Swaminathan's a paper. I mean, yes, I fully agree with her that despite all these reports, etc., in fact, very little has progressed. The OSH code, along with other codes, along with other labor codes, should ideally be thrown out. But what I would disagree is that I do feel that trade unions have done their bit. They have managed to unionize the ASHA workers. They have managed to unionize the ICDS workers, and that's a huge step for this form of unionization in the unorganized sector. So of course, we can always take this forward at some stage. So all in all, I think what I feel is that that the concerns have been expressed about certain neglected areas. For instance, Sandhya's paper also focuses on this entire aspect of lack of access, again, to something as basic as screening. So NCDs are there, but then screening is, I think, mostly in the private sector. Of course, is there also in the also in government, but then access again, I think is highly limited. And women, because of the way they're positioned, they're unable to really exercise autonomy in their as far as their health are concerned. And being a cancer survivor myself, I know the situation in fact, even in the cancer wards, in the private sector, there are hordes of people who come from distant parts of the country because there's just no there are no options, for screening or even care at that stage, and they do come at advanced stages, and they sell assets, and they come in absolutely in the last stages, and it's really pathetic to see how these people really sort of manage. So I think that economic deprivations are, I think, are fundamentally that they do lie at the base of that determine access. Of course, social determinants do also sort of play a role, but economic determinants ultimately sort of decide as to who is going to sort of get access to what kind of treatment, to what kind of screening, and of course, I'm not against CGHS. I was in fact a beneficiary because my husband is a CGHS beneficiary, but I would say that that it should be extended to everybody. I think we should in fact campaign for that a scheme like the CGHS should extend to everybody. So I think the excellent papers, and I think the concern that reflects through all these papers, it is what is paramount. And yes, we have to sort of bring back the public into popular discourse once again. Thank you.
Thank you so much, Rajalakshmi,
Yeah.
for highlighting all the key points from the chapters. So now I'm going to give a very tough task to Amita to summarize this entire discussion. I'll just very briefly introduce. It's my pleasure to introduce my friend Amita. Amita Pitre has more than 20 years of work experience in the social sector, primarily as a gender justice specialist. Currently, she works with Oxfam International on care within a comprehensive framing of feminist economic and climate just transformation. And Amita has undertaken policy research and advocacy in the field of gender-based violence as well as gender and tuberculosis. So Amita, over to you.
Thank you so much. The discussions have been so interesting that it is going to be really tough to pull them together. But I'm going to try very much, and Devki and Rajalakshmi have made my task easier. But first, congratulations to all my FPC friends and the authors because of the excellent papers and the excellent presentations that have come. It's a labor of love for Feminist Policy Collective and for the editor, Ritu Diwan, Dr. Ritu Diwan. She has done an excellent job here. Why we needed such a report? And that has come out very clearly, the sheer normalization of gender bias. For example, caregiving that several of you spoke about, Deepa spoke about it, Padmini also spoke about it, others also mentioned that whole thing about caregiving is a thankless job, does not need to be recognized while it works in the home as nursing for anyone who has a health problem, to our ashas and Anganwadi workers who don't need to be paid. This has been so, they're termed as volunteers rather than workers, and this came in again and again. Even the gender wage gap that Padmini explained, people refuse to accept that there is a gender bias there. Similarly, when you talk about health, many times there's evidence-based, medical evidence, and those kinds of language are used. They refuse to accept that there is a gender bias, but we know there's a lack of gender disaggregated data that also came up very clearly, but also because of women's particular biologies of, menstruations, hormone change cycles, doing research on women is very, very expensive. And that's why it is often neglected. And then the same drugs which are researched on men are used for women without cognizance of this. This came out in Sandhya's paper as well. So there's this lack of understanding of what constitutes gender bias in health, and that has been clarified a lot of lack of resources also, and a lack of a life cycle approach to health that also came out very, very clearly. I really love the framework which Devki presented of neoliberal patriarchy, explaining so many of the things that were discussed today. To that, I would also add the other lenses of casteism and ethnicity-related biases, which are intricately linked with not only neoliberal and patriarchal structural biases. And so we find actually that wasn't highlighted so much in today's discussion, but tribal women have the worst health indicators, and it is there in the details of the chapters that we have. And caste and being from a tribal area, from a tribal ethnicity, is strongly linked to poor indicators. I am also reminded of another framework which Geeta Sen had used in another context, and that is of systemic failures and systematic hierarchies. And I'm always reminded, 25 years back when I entered the health field, we were talking about these same issues. And now 25 years later, we are talking about the same things. And sometimes the systemic failures and systematic hierarchies explain the whole variety of problems that we see now, how the poor, the most marginalized women among them are facing the worst brunt of this, and the whole concept of a poor public health system being meant for the poor, and the rich will go to the private sector, has been institutionalized again and again. And not only that, we saw a whole, not only a push for privatization, we saw for decades, there's been only around 1% of GDP going to health by the state. And this remains. And not just that, the perverse incentives that it creates. We know, and we often say that health is too important to be left to the doctors. But in the NEET scandal, what we saw is it is so deeply implicated in the high level of privatization in our system. People are just dying to be doctors. They want to make lots of money. They want to be out of the regulation. Even the different kinds of safeguards that are in place. And with NEET, what we have heard is, even with the postgraduate NEET, is doctors are really not interested in learning how to diagnose and treat, but rather they're interested in their post-graduation. And, you know, something like a multiple choice questions cannot really teach doctors the complexity or even test who should be a good doctor. And we see this in today's complex, like the social determinants of health discussion. Gender-based violence is not recognized as a social determinant. Stigma related to health, which prevents diagnosis, is not recognized. Socioeconomic factors which delay diagnosis and result in much more complicated health problems coming to the doctors, not recognized. Nutrition and all the complexity related to who provides nutrition. Are we supporting the care workers, the mothers, those who are in charge of nutrition, is not recognized at all. We have been doing so poorly on nutrition for so many years, but there has not been that kind of a investment which needs to be there. And the whole perverse incentives that are getting created in, like the misleading excessive healthcare that is happening in excessive hysterectomies, excessive cesarean sections. Even what Padmini said, that if doctors are incentivized to misdiagnose silicosis as tuberculosis, we are doing something fundamentally wrong. Wrong in teaching our doctors, wrong in the public health moorings of our health sector, wrong in putting too much of emphasis on curative care and not enough on social determinants of health. All of that, also very, very poorly financed healthcare systems, no budgets for screening, no budgets for mental health, no meaningful implementation of suicide prevention or even trans health. All those issues which we know and we have known for so many years as a problem, but those have not been addressed at all. I would also like to talk a little bit more about things like, for example, amongst the perverse incentivization that we saw, there is this also, this thing is now same-sex relationships are no longer criminalized. At the same time, sex work per se is not criminalized, but this whole nexus of how legal issues interact with social mores and how they create systematic barriers. Again, this is something that is a socioeconomic determinant of health, but not at all emphasize. There are several of these things which come together in this report, and I would urge everybody to please go and read it. And also those of you who are journalists or otherwise commentators, etc., please go and please write about it. Please spread the word and use it for your policy making. I hand over now to Ayman for Thanksgiving.
Thank you so much, Amita, for summarizing the report and the discussions today for us. I would like to thank Jashodhara and Elangi for organizing this webinar, and our brilliant speakers for sharing their very important work with us. Our discussants who added a lot of depth to the dialogue that we had today, and also to our participants who took time out to join us for today's discussion. Thank you so much, everyone.
Thank you,
Ayman. We
everyone.
will officially close the webinar now. Once again, thanks to the presenters, the discussants, and all the attendees, and asking all those questions and engaging with the conversation. So whenever there was one question about the recording, I'll just say that the recording will be available. We will put it on the website, FPC website, and share the link with all those who have attended today. So you can refer to the recording. And the report, as soon as it is ready, we will also upload it on our website and share the link with this group. I hope this is like all of you are okay with Feminist Policy Collective contacting you and sending some of the relevant material. So hoping to keep in touch with you, and maybe you can also, Ayman can later send about the sort of how do you get involved with activities and updates via listserv. So thanks a lot.
Thank you. Bye. Thank you.
Bye.
Thank you, all of you.
Thank you.
Bye.
Bye. Good to see all you guys face to face.
Same here. Same here. Bye. Bye.
After decades, I think.
Yeah.
Yeah.
See
Okay.
you.
Thank you very much for getting me involved.
Yeah.
Thank you.
Yeah. Bye.
See you soon. Yeah.